Hi, and welcome to Chronically, formerly known as Concussion Talk Podcast. My name is Lauren Zayaks,
I'm Nick Mercer.
and we're teaming up to talk about all things chronic illness. We'll still be talking about chronic concussion, but we're going to follow a lot of other journeys along the way. So make sure to subscribe and check back in. Thank you so much for spending your time with us. We have the incredible Dr. Stephen Broglio joining us from the University of Michigan Concussion Center. Welcome, and can you introduce yourself to the listeners for us?
Oh man. Well, thank you first for having me on. And Nick, we had a chance to talk. I can't remember if it was last year or the year before. So I'm glad we got to revisit.
Yeah,
So,
yeah.
yeah,
Right.
Steve Broglio here at the University of Michigan Concussion Center. This is year 15 for me here. And I am currently a faculty member in the School of Kinesiology with appointments also in neurology, physical medicine, and rehab. And I serve as the Associate Dean for Graduate Affairs for the School of Kinesiology. So a man of many hats, as they say.
Lots of time for hobbies.
Yes.
And yeah, so you play football or because I shouldn't because in your articles are a lot of football and stuff. But do you play football or what sport do you? I know you're an athletic trainer, but
yeah, when I was younger, I would play the international football, soccer, but never played American football. Hard to see on Zoom, but I do not have the body to play football. I would have been broken in half.
You could have been a wide receiver.
I'm not that fast, so I do not have the body.
You could have been a kicker.
Kicker?
Maybe a kicker. So yeah. Yeah, never played. I mean, it was definitely around in high school, and obviously I went to some big football schools in my training, but yeah, I enjoy the game, but never played it.
Yeah, I remember you went to Georgia for a PhD. Or your master's, right?
My PhD was at Georgia. My master's was at Pittsburgh, so not
Pittsburgh. You
not
went
entirely
to, went to. I was just listening to our podcast today, so I'm all caught up on your background.
There you go. Yeah, and Carolina for my undergrad. So a little bit of basketball, football, kind of were the main sports for those schools.
Nice.
And Michigan, of course, everything. So
Yeah, exactly. Yeah, it's a big school. I never seen the population size, but the two studies that we kind of focus on because Lauren is actually doing a lot of the good research on this stuff. She's right into this space, so I kind of about her in this. But you've done a few studies on concussion in former collegiate athletes and the military. So I know for in terms of long-term study, long-term conditions due to concussion, what have you found are the most glaring, or the most obvious?
Yeah. So we just published a paper, I think last week or the week before, and by we I should say my doctoral student Adrian Boltz and a former postdoc Landon Lemke. They were the co-leads on it. But we were looking at former collegiate athletes that were now up to 5 years after graduation. And we really see this pretty clean stepwise progression as the number of concussions increased, the risk for I don't want to say cognitive deficits, like mental health challenges starts to go up, right? So depression, anxiety, things like that. So it's not a one-to-one, like, you had 2 concussions, you will therefore now have anxiety or depression. It's just the risk of those things appear to start increasing. And this seems to line up a little bit with what we're seeing kind of in other populations that are being studied by other groups across the country. I do think unique to our study, though, we had contact collision sport athletes, so football, ice hockey, lacrosse, but we also had what we would term kind of limited contact athletes, so like basketball is a good example, and then we have non-contact, so our track and field or swimmers, and it's really not the level of contact or even the years that they had played their sport that predicted this sort of stepwise. It was all primarily driven by concussion history. So I think that's a little bit different than what we've seen in the literature, where some of them have suggested it's the years of exposure. But I think kind of to sort of like put those two things together, the more time you play a sport, the greater risk for injury, right? So if you're just counting total years,
sure,
the odds of you having
deciding.
more concussions with more years sort of is kind of built into that. So that may
Yeah.
explain some of it.
Yeah, so I know. So you think I think I remember kind of seeing a general idea that's more, for lack of a better word, severity of injury of a concussion, and can you just explain what you said in your study? You mentioned a bunch of times long term, and what you mean by long term.
Yeah.
So like
So
symptoms.
yeah, so we didn't look at injury severity. So like really the best way to classify that in my mind is sort of the days out of sport or the days
Yeah,
until
yeah,
asymptomatic. We did not look at that. So other papers may have done that, which is a really interesting question, right? So, but we just didn't do it. And as far as long term, like I said, the cohort that we just published on, they're about 5 years after graduation. So they would have been, 5+ years removed from their most recent injury. I think what you're getting at is like long term, as we really think about it, is like what happens now when they're like 40s and 50s and 60s,
yeah, yeah,
and we're working towards that. I think the design of the project, the CARE Consortium, and I think we can talk about what it really looks like, but is to initially enroll people when they're undergraduates at their college or university, and then literally track them all the way through death. And so we're just sort of in the earlier phases of that portion of it. I mean, we'll get there with time, of course, but that prospective longitudinal tracking it's a very nice study design, but it takes a lot of time to
yeah.
get to the sort of final answer.
That's really interesting. I didn't realize how long y'all were going to be able to continue that project. So the plan is to end of lifespan if possible. Does that mean it could potentially lead into some better prospective data for things like CTE? Is that a hope?
Ideally, yeah. So we're having early conversations around brain banks, and then kind of we're not. We want to make sure we're not limiting this just to CTE. So it's really like all brain health, right? And so that could be all the neurodegenerative diseases that sort of fall under the tauopathy umbrella, and other categories. So that's sort of the idea. And I want to, the work that's been done in older athletes to date, brain banks, or even 60, 70-year-old athletes that are kind of providing clinical data, that's important work because it sort of guides what we're doing. But I think to have this true prospective design for those that are like the research nerds, like they sort of understand that it's a stronger model, and we can make better associations as we're going forward.
Yeah, that's really interesting, especially, working in this space and predominantly treating patients with chronic injuries, even if they've only had one or two, you always are going to get a question about like, what are my risks of
Right.
CTE? And my answer just really has to be, we don't know, like stay tuned for the next 30 to 40 years. What we do know is we should treat you now. Like we should treat your migraines and your mental health and your
Yeah.
exercise intolerance
And
now.
yeah, that's a super important point, because I think there was a time when concussions and then CTE were sort of portrayed in a very negative, like there is no treatment, no anything, and you're sort of
Or was it a
doomed to this
one-to-one
poor
ratio
outcome.
even? Yeah,
Yeah. So, but like I think you're spot on. I mean, like depression's very treatable, anxiety is very treatable. Like a lot of these things are treatable, and we know a lot more about brain health, maintaining brain health across the lifespan. So, good diet and exercise and sleep and those types of things that are I don't want to say they're no cost. There's some cost associated, but they're not astronomical costs.
The health behavior costs, the hard stuff.
There you go. There you go.
Yeah. I actually have a question going back to the number of athletic exposures is usually how that's reported, right? Versus the number of concussion. It was really interesting, your findings. I didn't get a chance to read that paper. I was digesting 400 other ones that you've written recently, but I didn't get caught up to last week. But it is interesting because our inherent bias would think contact sports have more subconcussive hits.
Yeah.
So therefore, even if you report 5 concussions, we should estimate that you've had X number more than that. So hearing that these low impact and non-impact sports weren't significantly different is really interesting because it alters our biases and our cognitions of what we think we should be looking for later on.
Yeah, so I may have misspoke. So there is a very small effect for the contact level,
Okay.
but the concussion, the effect size for the concussion is really the big driver there. The other thing that we didn't parse out was, we lumped all of our contact collision sports together, right? So football, ice hockey, lacrosse, they have very different exposure profiles
yeah,
across them, right? So football probably is the most exposed, and then maybe ice hockey, and then lacrosse after that. Soccer would be up there too with the heading. So it would be interesting to pull the football athletes out and look at them sort of independent of the other categories, or even go sport by sport and see what it looks like. And we just haven't done that yet. So it was sort of just that first pass to try to understand like what's the overall data showing us, and then we could start digging deeper and get a better sense.
You wouldn't do that to your doctoral students.
On occasion, I have been known to like, hey, if you have a few minutes, can you just run a quick table so we can like look at this to guide what we're thinking here. So,
and you probably have the volumes then to run, like MANOVAs, to run those types of statistics, right? Because you're talking about thousands of exposures over time, or thousands of sample size versus a normal studies, 12, 20 patients. But y'all have that, 4,000 patients kind of sample size, right?
Yeah. So I think the sample in the most recent paper was around 4,000. We have another cohort that we're working on collecting data on that's up to 10 years after graduation. That's with the military and the civilians. I think it's like 11 or 12,000. So we'll even get more granular there. Yeah. So we couldn't do the analyses on every sport because it does start to get thin in a couple spots. But we can do it on, I think we had 26 total or 28 total sports involved in the initial phases. And I think we have enough data where we could do like 14, 15, 16 of them, somewhere in that neighborhood.
That's fascinating.
Have you ever done the comparison between collegiate sports and military? Like the incidence of concussion there or brain injury there?
Yeah, so I had a doc student a few years ago who did look at sort of the rates of concussion in the civilian cohort and then relative to the military cohort. So this is while they were still on their at their respective institutions. It's been a bit since I've seen that paper, but my recollection was that the military cohort had higher odds or higher risk for concussion because in addition to particularly the athletes, right? So the athletes have just all the regular risk for participating in the varsity sports that we commonly think of. Then they have their military training on top of it, right? So the combatives training and the basic training and all those things. So that just adds another layer of risk to what they're doing. And so I think that's sort of an important understanding when we're talking to our military partners is sort of, they want people with high cognitive functioning because they're making decisions that affect, these are cadets that become officers and they're making decisions for, I don't know all the military terms here, but divisions and platoons. And so they want to make sure they're making really good, accurate decisions going forward when they're leaders in the military.
That would be ideal. Yes.
Yes.
When you're talking about the CARE Consortium, can you just detail that for us just a little bit? Those of us maybe who don't know all of the details and how exciting the funding is and all of the great public health that we're going to get out of that project.
Sure. So the project started in 2014, and it was a joint effort between myself, Tom McAllister at Indiana U, and Mike McCrae at Medical College of Wisconsin. Joint funded by the NCAA and the Department of Defense. The initial phase of the project, which is what we would term CARE 1.0, involved 30 institutions from across the country. There were 26 civilian sites and the four military service academies. At each of the sites, all of the varsity athletes were eligible to participate. And then at the academies, it was every cadet on campus. So at a place like Michigan, we have like 900 to 1,000 varsity athletes. At a place like West Point, I think they have 4,000 to 4,500 cadets. We would get about depending on the site, we would get about 90 to 95% participation. So we had really good participation. Every person that was enrolled got a baseline evaluation, and then we would get them at about 5 post-injury time points if there was an injury that was diagnosed by the local team. There's some kind of repeat baseline testing in the early phases, which then went away later. But that was sort of the early portion of it. There was a subset of sites, 6 sites that also completed the advanced research core. So that involved helmet sensors for the football athletes, imaging, blood draws, genetics. So if you want to think about it as at the 30 sites, it was like a very broad but very shallow set of clinical evaluations. And then at these advanced research core sites, a very narrow number of people, but a very deep assessment that they went under. So that was the first phase of the project. The second phase of the project, CARE 2.0, we were evaluating people within 1 year of when they graduated, right? So basically your seniors that are kind of on their way out the door. And the intent there was to, like, what does a collegiate career do?
Yeah.
And then the second part of that second phase was what happens within 5 years of graduation, right? So that was the paper that we started talking about a couple minutes ago. The current phase of the project now is what happens up to 10 years after graduation. So that's the 12,000 or so people that I mentioned between the military and the civilians. They completed about an hour or so long online evaluation. And then we have a subset of individuals, about 2,000, 1,000 military, 1,000 civilian, that are coming back to locations and doing in-person visits. And that's a full, like, all-day evaluation. So full neuropsych, imaging, blood draws, clinical exam. There's a subset of that subset that's also getting PET imaging. And so we're still in the data collection phase of that. But I can tell you just at sort of high level, like, these trends that we were seeing at 5 years continue 10 years out. So, but we're going to start doing like a deep dive into the data probably in the next month or two is the plan. So
Be very excited to hear what comes out of that.
We're sort of, I think this is like the exciting time to be a researcher, right? So you get that fresh data set, right? And it's like, I know what I want to look for, but I don't know what I'm going to find. It's a little bit like Christmas, right? Like you're unwrapping and sort of seeing what's there, and like you ask one question and that ultimately leads to 5 other questions. So it's a lot of fun. This is the exciting time.
I have a question about the need. So you had the CARE Consortium is of military and varsity athletes. So what led you guys to group those two together? Say civilian, military, and elite athletes, like say University of Michigan football and someone at West Point who's not playing sports. Like, what was there? Was there a paper or study or just a general idea that maybe there's like something associated in these two populations?
Great question. So if you think about the cohorts, the civilian and the military cohorts, right? So you have individuals that are kind of 18 to 22, 18 to 25 years old on both sides. They are both really at the peak of their like cognitive and physical abilities, right? And they are both sort of like pushing themselves for that physical excellence, right? And cognitive excellence. And they are both exposed to very similar mechanisms of injury. So at our varsity athletes, it's very clear, but in our military athletes, our military military cadets, every cadet at each of the academies is mandated to participate in either a varsity sport or a rec sport. And that came out of World War II, where they sort of recognized that the American soldiers weren't quite as fit as they needed to be. And so they put in place this regulation where they had to participate in a rec sport if they were not a varsity athlete. So that, and then on top of that, if we think about, we commonly think in the military setting around like blast injury and projectiles and those types of things. Somewhere, the numbers vary a little bit, but somewhere around 80-85% of concussions in the military are from blunt force trauma that happen what they would term in garrison, which is not during combat, right? So they spend the majority of their time sort of like training and getting prepared, very little time in the like combat space. And so that mechanism of injury is actually quite similar between the two cohorts. And then there was this shared interest, like what are the long-term effects, right? So the NCAA, I think it's pretty obvious like why they were interested, but then the military, particularly coming out of Operation Enduring Freedom and Operation Iraqi Freedom, they were very interested, as TBI became the signature injury of the wars, they were very interested in like what's going to happen 10, 20, 30 years down the road. So that's where the sort of joint interests came.
It's also nice that they're contained populations as well, because for the research purposes, correct?
Yeah, I mean, there's you could not do this study in like general population, right? Because you can't baseline the world, right? So there is sort of a known injury risk for both of them, and then they're accessible. You can do that baseline evaluation. So yeah, it does sort of help on some level, but it also limits on kind of what we can say, right? So how the varsity athlete recovers is not going to be how, I don't know, a general Michigan student who slips on the ice is going to recover, right? And same thing with the military side. So there are limitations to it, but these are sort of the trade-offs you have to make when you're doing research.
Okay, so just when you said, because I know in your papers you said they're non-varsity athletes, and I was thinking like, well, what about like people play like intramural sports or just rec sports? But like, man, but when you mentioned that they have to play sports in the military,
Yeah.
that
Yeah.
makes a lot of sense.
Yeah.
Is there? I know you said the most are blast injuries, but is there like a general relationship between say a person in say rec sports in the military versus a player like Michigan University of Michigan football hockey player, like the nature of the injury like torsional or is like blunt force or
I mean, my personal stance is blunt force trauma is blunt force trauma, right? So like a 98G acceleration to the head from an impact that occurs on the like left temporal lobe is the same mechanism as the Michigan kid, right? The varsity athlete versus just the regular student.
Mhm.
I think where the difference, a few things play out and kind of after the injury, I think that really affect, right? So some of it can be the context of the injury. So the football athlete sort of may recognize like this may happen to me and it's just part of the game, right? So their sort of mindset going in is one thing, as opposed to somebody that's like maybe in an automobile accident where the passenger died, right? Like that
Yeah.
puts a whole other layer on sort of like the post-injury experience. The other part of it is the access to medical care afterwards, right? So the varsity athlete or the cadet, they have great medical care. They can see an athletic trainer like every day, right? And they can go in and they can be managed and they can get clear guidance on what they can and can't do and move them through. They can get reduced classwork if they need to. If you are maybe not so much for the general student, but if you're just somebody in the general community, and I don't remember the numbers here, but I think it's like 25% of people get follow-up care from concussion, or maybe 50%. I don't remember. It's a low
If
number.
they're lucky. Yeah.
Yeah, it's a very low number. So, and there's somebody in my personal world who's sort of like dealing with this right now. They had an injury 6 or so weeks ago, undiagnosed in the ED because they were more concerned about something else. And then I'm talking to them and I'm like, hey, you got some post-concussive symptoms going on. Right. So
Yeah.
I'm trying to like manage, like find them some care so they can like, be treated. But this is somebody I personally know. And like, that's not everybody has that access. And I get that.